If I'm so focused on what AI is doing and focused on like what it is contributing to the world, and I lose sight of what it is that I'm doing in my growth, then it's like I become a part of that wave. And how do we begin to recognize when we're being influenced instead of being the influencers?
From Research to Real Life, a podcast brought to you by the Clinical and Translational Science Collaborative of Northern Ohio.
Well, welcome to episode 2 of From Research to Real Life. We are excited to be back for a new episode. Thank you so much for joining us. Today, we are talking about something every researcher, no matter the field, has to navigate: methodology and technology. So, what do we learn from the past? What do we embrace from the present? And then how do we take these two to form a better future for research and for outcomes in this field? I'm your host, Lora Parent. I am joined today with 2 fabulous researchers. Our first guest is Dr. Shanina Knighton. She is a nurse scientist and infection prevention expert whose work bridges technology-based interventions, implementation science, and medical device innovation. She's a former case scholar and pilot awardee from the CTSC. And Dr. Pfoh, welcome. She's a health services researcher at Cleveland Clinic's Center for Value-Based Care Research, focused on patient-centered outcomes, care delivery, and systems improvement, and also a former case scholar. So it's such a pleasure to have you both. And today we are talking about methodologies and technologies and how they kind of shape our research choices and how they kind of span across generations of researchers and how it has really impacted both of you in your individual areas of research and interests. So I want to give you both the opportunity to talk a little bit about your research, your interests, and how maybe these things have guided you over time and what you're doing as new technologies or new methodologies come in across the paths, what you're learning from other researchers and how that has impacted you. So let's dive into it. Let's start with you, Dr. Knighton. Shanina, if I may.
Absolutely.
Okay. So you've built a career in infection prevention and implementation science. Can you tell us about how maybe methodology has impacted your research? Talk to us about your research, what you're doing, and give us a little bit of an introduction to where you are right now.
So that is a loaded question. So I always say at the beginning, so once a nurse, always a nurse. And so my nursing background is what led me here. As we can imagine, we had H1N1, which was one of the first pandemics that I had experienced as a nurse. And so that kind of spawned me into infection prevention and control. And so while I noticed all of these mechanisms for healthcare workers, there wasn't really many for patients. And so I always ask, even at that time, I was a pregnant mom, how do patients keep themselves safe? And so as I continued to ask the question, I found myself here at Case Western Reserve asking the question. And so that was during the PhD program. As you can imagine, with methodologies, I was able to borrow, from the health belief models, theory of planned behaviors. And over time, just because things have happened, we're going into more of that implementation space, more of a space of where we're looking at translation. And so I started to use a different model, which is the behavior change wheel. And so what it does is it takes these theoretical domains and frameworks, including a health belief model, theory of planned behavior, and it puts it all into a combination. And so my work is around COM-B, which is at the center of that. How does capability, opportunity, motivation lead to behavior change? And one of the things I'm focused on right now is patient hand hygiene. So how do we get patients more involved in being able to clean their hands at the bedside? Okay. And then not only just doing that, but how do we get them to self-manage? And so the ways in which I've been able to do that is implement technology in a way to where it's not always on the nurse to do everything. Because whenever I said patient hand hygiene, it was, oh, just have the nurse do it. And I'm like, we don't need one more thing. And we all know we've been cleaning our hands since our mothers told us to, since we were babies. So it's really about how do you make sure that patients have that capability, opportunity, and motivation to be able to do the behavior, which is to clean their own hands.
Wow. So it really started as a practicing nurse.
Yes.
And then kind of fueled your entire future career. This one maybe quick opportunity. Was it a patient? Was it an experience that you had that kind of really jump-started your research question or your problem that you wanted to solve?
It was. And I know that there's always that saying about the butterfly effect and how things amplify. So I had at that time my husband's grandmother. So she had had a stroke and she was only able to use the left side of her body, but she was a very meticulous woman. So we would watch her pick the dirt from up under her fingernails and ask for her hands to be clean. And then I had it again with my godmom. And so she was passing from cancer. And I'm like, well, why haven't you eaten your food? And she said, no one's come in to clean my hands. And then being in the clinical setting, and this is when I was a novice at research, I literally would take tally marks and go around and talk to other nurses and say, did your patients clean their hands, or did you have to tell them? Or I would even make note of when I had to remind my own patients. So I would say that those things is what kind of spawned it, and it just kept getting louder and louder, especially even now. I still have people call me and say, oh my gosh, my mom was in the hospital and she didn't have anything to clean her hands, but I thought about you and I made sure that she had something. So it
that's
still
great.
continues to invigorate me every time I hear those stories.
Sure. Yeah, absolutely. Yes. And now, Dr. Pfoh, Liz, if I may. Yes. Okay. So you work kind of at the heart of value-based care research and health services research. So what drew you to that space? And tell us a little bit about your interaction with research and what was the one thing that got you started?
First, let me just say I loved your explanation, Shanina. And one of the things that really sang to me is how you talk about how it's patients. And when we think about outcomes, it's really about helping a patient live a better life wherever they are at that stage, and holding that. And to add my own story, the reason I got into this is because my grandmother had a stroke, and they were trying to decide whether or not to put her into the hospital and do surgery, and she probably wasn't going to make it. And there was this choice going on where it made sense that of course she would do the surgery, but really she wasn't sick enough. So Shanina, as you talk about hand hygiene, it seems like, oh yeah, that makes sense. But in real life, it's so much more complicated than that. Mm-hmm. So in my research, I feel very lucky to be here now, where I grew up working as a research assistant in New York City when they were implementing electronic health records. And it was this really interesting time where physicians were transitioning from paper to electronic health records. And did that technology help? And it made sense that it would help. But sometimes physicians are really smart people, and they wouldn't use the system the way we anticipated, because they used the system in the way that worked best for them to care for their patients. And then we've had these all unintended outcomes. And I've built my career over time working with electronic health record data, which is a little bit more distal than your work, which is why
but we
find
need
it
it.
fascinating. Yeah, we need both.
Yes.
But to understand what patients are uptaking care, what patients are being given different types of care, and trying to understand the why. So a patient might not be given a certain what we would deem high quality care because maybe that's not what they want. That's not who they are, and patient-centered care is also really important. So trying to tease that out now that we have electronic health record data on large populations of people, I think is my day job.
Yeah.
So talk to me about how you have blended maybe things that you used to start with. So, as early back as the pen and paper, keeping tally marks with EHR. We are taking voice notes. We are scribing in one notepad and then we're transferring to another. And so how do we maybe effectively blend both technologies? Both are technologies in a sense, right? The pen and paper is a technology and typing into the computer is another. So how do we merge those two, but then also do that with efficiency, quality control, and making sure that everybody's working on the same page.
So I can tell you one of the challenges that I had as a nurse is, and I'm sure that physicians are the same way, is that when you're doing documentation, we learned how to, I would say, do a shorthand documentation. So the way in which I may put in notes may not necessarily be the boy ran to the store. It's going to be context clues of words that's still going to get to the end point, but somebody in the medical field would be able to read that. And so now what we're seeing is how does that change like the level of writing? And so EHRs being able to recognize that shorthand right and being able to translate it into something that's accurate, I think is a way in which it could be useful and helpful. I think that would be my biggest take on it in terms of how it would be useful.
And with that, I would say carefully, right? Like you try and use new technologies, especially if we think it can help patients get better care, if we think it can help ease caregiver burden, because documenting within the EHR is a lot and it can lead to burnout, and that's not necessarily providing care, right? So how can we make sure that we're building a system and a process that helps patients have the best health possible? But when we implement it, we have to evaluate it, right? And we have to think carefully about, is this doing the thing we think it's supposed to do? Are there any processes that might be unintended consequences, like something gets missed or something that gets documented the way it wouldn't? And I think it's everywhere. I will say I went to the vet recently and they started using an AI scribe. So it's coming. Adopting it and making sure that it improves things is really important.
Instead of taking away.
Yes.
I agree with that. Assumptions too. And I think that's one of the biggest things is that AI is in a way, like it makes a lot of assumptions. And sometimes those assumptions can turn into biases that may not necessarily reflect the care that's needed or the care that's given. And so even as I describe it now, just within healthcare, particularly related to nurses, is I think our healthcare system is more reactive instead of proactive. And as a reaction to everything, there's a new technology, there's something that's trying to be implemented to be able to improve safety. But those very things that are intended to prove safety are actually leading to those unintended consequences and doing the opposite of what it's supposed to do. And when we think about, like, let's just say human implementation of it, they say that, like, literally we're having proliferation without integration because it's very hard to get someone's brain to be conditioned to their existing workflows, being able to put into the mix also this new technology that now they have to become accustomed to learning, but then they're already inundated by making sure that they accurately document what is needed. And sometimes those technologies that come in, the way in which I may be trained as a provider may not necessarily translate with what it is this technology is doing into the system. So if this technology is doing that work, it very well may leave out some key indicators that I would have documented as a key step that could have been very helpful to, let's say, maybe an early warning sign for a patient.
I think that's exactly right. I have 2 points to build on what you said. One with like how we think. If we are given a story, then our mind wants to fill in the blanks of that story. Whereas if it was a blank page, we might think more expansively. I'll tell you, I recently got an R34 and we were thank you. So excited. Thank you, NIH. And we were filling out the clinicaltrials.gov, and it's very focused on a patient level clinical trial, but I'm doing a unit level clinical trial. So the person who was helping me fill it out, like, kept getting into this doesn't feel right? Because she was getting pigeonholed into what probably made sense at the time, but didn't fit my problem, didn't fit my clinical trial. And that's what happens sometimes in care, where you're given like this answer and you have to answer the questions. And these are very busy people who are very smart, but have to process a lot. And our human brains only process so much at a time. So I think your point about what we give and then what gets documented versus thinking more expansively, I think it's really great. The other part I wanted to bring up was how you were talking about how different people document, and we all speak differently. You'll notice that there's some words I say, like idea, that are incorrect and my friends find hilarious. But if when you're documenting, the AI algorithm is built on like one set of a population. And we have a really diverse set of healthcare providers across the nation who might speak and document differently than what it was originally built off of. And understanding like how much does this algorithm generalize to our patients and our clinicians and how they type and think, I think is a really important. So I just wanted to agree with that comment.
Yes. And I love it because, I mean, just in terms of how you framed it, that just gave me a different way to frame it. So thank you.
So talking about AI a little bit, it seems as though it's just moving so fast. How do we handle the fact that maybe it's moving a little bit faster than we would like, and we're not able to put in maybe some methodologies that would have a standard level of care or baseline for providers or for nurses inputting information into the machine, the system, and giving us different outputs all around? How do you combat that?
I would say, for one, being true to yourself and being aware of where you are. And it's not to say ignore AI, because AI is here. But I think the more we come to understand it, then the more we come to understand ourselves and how we do continue to have, I would say, critical thinking and independent thought. Meaning that if I run a math problem, let's say myself, and I'm doing it by hand, and then I'm like, okay, let's see what AI has. It's okay for me to still believe in my own results if I follow my own methodology. And I just think sometimes with how things are built and how fast it's going, we understand that these systems are sophisticated. I understand the statistical analyses is going to be maybe way far sophisticated than what I learned in my PhD program and what I continue to practice right now. And it's okay for me to continue to be where I am and process it based off of that level. And so I think comparison is the thief of joy. And so the challenge is that we have to ask ourselves, am I being true to myself and my level of growth as a scientist? Or am I being influenced by something that I'm not prepared to embrace or understand? Because they say if you're not a part of the solution, then you're part of the problem.
Right.
So if I'm so focused on what AI is doing and focused on like what it is contributing to the world, and I lose sight of what it is that I'm doing in my growth, then it's like I become a part of that wave. And how do we begin to recognize when we're being influenced instead of being the influencers?
Oh, I love that.
And I love how there's like trust yourself in there, right? Like if this doesn't seem right, and I think that goes back to the earlier conversation. If something's missing, if the numbers don't seem right, what's going on? And for me, as someone who is a researcher by training, not a clinician, working with my clinician partners oftentimes and saying, does this number seem true to you? Is this low? Is this high? What's going on? And I think we do have a lot of methodologies that we can use and apply. And I will say I have a 50% operational role. And I use a lot of the skills I have as a researcher to do these like rapid cycle analyses operationally to say like, are we missing people? Or who, we have this identified list of high risk people. Are there other people who should be in there or shouldn't be in there? And that's just using regression analysis and like looking at the data and looking at the populations. I still think that a good graph tells a huge story, and it's not advanced, but it helps us understand the world, especially as we're including AI in it.
What have you both seen as maybe some of the biggest hurdles trying to either implement something new, because we know it takes, the standard of 21 days, right, to adopt a new habit. We've heard all of these kind of theories about adapting to change. It is very hard. We are creatures of habit down to the core.
I laugh because you talk about 21 days for a habit. It's 17 years, I want to say, is the average for uptake of a change in practice.
Wow.
Yeah. And a lot of that is culture is one thing. We also have to be cognizant that the landscape of healthcare is changing. And so whether it's becoming more preventative, resources, are shifting. So things are happening, and that's going to automatically mean that we have to look at things a little bit differently than what we have. And so there's always going to be competing priorities. And so I'll tell you, even with my area of research, with Liz's area of research, and what it is that we're doing, some may say, hey, you're doing something that may sit on a shelf for years, or it can very well be something that literally they're going to say, hey, Dr. Pfoh's research is valuable in this particular moment, and her methodology, we need to pull it back off of the shelf if it was on the shelf, or she's still working on it, and maybe there's this piece that needs to go with it. It could be the same thing with mine. But I think the thing is, what keeps us motivated is that some of these problems are still not resolved. And so as I'm looking at self-management, we saw with the pandemic, infection prevention is not just a hospital-based thing. It's not just something that happens, when you're getting care. It's going to happen in the community. It happens at the grocery store. It happens absolutely everywhere. And so my thought process and how I move is, how do I move it beyond just the walls of research? How do I move it beyond just a publication? And more so importantly, we are good stewards of taxpayer dollars. So how do I make sure that the work that I'm doing is actually going to get to everyday people? And so that is my biggest thing of what it is that I'm focusing on now. Of as long as I continue to reiterate the message of how infection prevention fits into our daily lives, use evidence-based practice, use science to be able to do that, then it's like by the time we make it to that 17 years, it's like it's something that's been building up instead of me waiting in order for it to be embraced. So I would say that that's how I overcome the challenges, is understanding that it's not necessarily a hurdle or a challenge. It's a marathon.
Yeah.
So
Before I talk about my research, Shanina and I were KL2 scholars together, which was like such a joy for me in learning. But one of the things I remember, and hopefully I'm remembering correctly, is that you did a lot of testing too when you were building hand hygiene. And one of the things that I was thinking as you were talking before is hand hygiene makes so much sense. But after you explained why it's difficult and why it's difficult for a hospitalized patient, and that difficulty might be different for different hospitalized patients, I was astounded about all the things I didn't think about. So would you mind sharing a little bit about how you did some prototype testing to make sure that it was uptake?
Yes, thank you for that. So the technology that I'm currently testing out right now with the RO1 through National Institutes of Aging, I'm in year 4, is a patient smart hand sanitation dispenser that affixes to the patient's bed rail, and it reminds the patient when and how to clean their hands. But it gives verbal reminders opposed to the standard beeping that they would experience. And to what Liz is mentioning, I didn't start there. So it took, my CTSC pilot funding. It took the KL2 scholars funding. So it took this building up in order for me to be able to get there. So it started out, I showed a video during our scholars program, and it was a video of a patient that was struggling to open up the towelette. And it literally took him about 2 minutes to open it. He spoke about the neuropathy in his hands. He talked about wanting to be independent and not wanting nurses to do it. But then after I spent that time of him opening up that packet, I cut the video off and I remind people that he still had to unfold it 8 times before he could use it. And so someone that is weak, they're hospitalized, that's going to be hard for them to use that towelette. So I thought about that. I tested out wipes. And so I had done an intervention of where they put wipes on top of the tray. Patients complained about them drying out before using them. So I'm like, okay, well, maybe that's not convenient. We tried the pocket size hand sanitizers. They had issues with flipping the cap up because of strength in their hands. And so then when we settled on a push down pump, and we would put it on a bedside table, but the table would move around because, of course, the priority is for caregivers to be as close to the patient. So then if that bedside table wasn't there, they still couldn't clean their hands. And so all of these things is what ended up us coming up with a design that would be within close proximity to the patient, testing out beeping reminders. There's a lot of beeping already, but if there's a sound, and it's Mr. Jones, can you please clean your hands? And it's directly talking to them. I can now augment the voice of my provider and telling me to do these things, opposed to me listening to another beeping sound and me having to remember to practice, which again, we know patients, it's not that they don't want to, they're just not in that right mindset. So thank you for that.
I was so impressed hearing about it. I love how you're meeting people where you're at, right? I did get a master's, and what I learned in my master's of health promotion is essentially people do what might seem irrational for very rational reasons to them. So to answer your earlier question, what we often do is look for differences, like look and see who is uptaking it a lot and who's not using it at all, and then we talk to them. Why do you like this? What is useful to you? What are the perceived benefits? What is the culture? What are your leaders saying? How does this fit in your workflow? And then we talk to the individuals who are not uptaking it. What are your perceived benefits? What are your perceived barriers? Where do you spend your time instead? Because oftentimes someone's not doing something because they value something else. And that could be honest, true valuation of that. So,
and AI can't do that.
Correct.
AI can't do that. Yeah.
Absolutely.
So let's talk a little bit about your future. What are some things, whether it be new technologies, whether it be new methodologies, maybe new opportunities for AI, collaboration? What are some things that you are looking forward to that will, help your research, help your products, help implementation of the work that you've already done?
I want you to start.
I will say I'm super excited to be here. I just essentially hit like mid-career. So one of the things I'm excited about is this uptake of natural language processing AI models. And I will say earlier in my career, I heard about natural language processing, and it just seemed too specific to where the population. So there has been a big move where it is way more generalizable. So how can we make care better? When I'm also interested in subpopulations. So as we think about population-based health, you can move the health of the entire population and leave some populations behind. So as we look at AI and how it's helping, hopefully, and evaluating that, both operationally and research-wise, is anybody getting left behind? Why and how can we help move them along too? So I am particularly interested in that and mixing this large EHR data that we have, that we can understand populations, what they're using and what they're not, with talking to people. One of the other things I'm really excited about, I've been working with Dr. Dalton and Prudzinski on an R grant that they have, where we're also looking at community factors. So how does where you live impact the care you're accessing, your diagnoses, etc., so that we can understand that maybe it's harder to access care in a particular place. Maybe it's easier. So thinking more broadly on how to help people.
I love that. You brought up something that I think is exciting. And that is because you do see the focus. You hear these terms, right, of like big data, big data, big data. And then it's like you're capturing the big data, but then oftentimes those other populations or the smaller factors that are impacting maybe a few get forgot. But that is sometimes something that's interesting because it tells a bigger story. And then when you see problems that start small or they start with small populations, being able to say, how is that growing over time? Because oftentimes that's something that's missed, where it's like, okay, well, yeah, maybe 2,000 people started at this, but then you're checking back 5 years later and you're like, oh, I just queried this and now it's 12,000 people that are in this category. And it's like, what has happened in order for that to be able to increase? So I'm excited that I'm going to use the term of, you not necessarily, and it's not a term, but just the fact that you're not forgetting about the forgotten
Yeah.
in regards to the approach that you're taking, which I think is very exciting.
Thank you.
Yeah, so I love that.
We've seen a lot of retroactive studies being done through the CTSC because now EHR has the capabilities to kind of look into a window of the past.
Yeah.
And so I think that's really great because now we're able to see things that maybe we weren't beforehand and make some tweaks along the way. Get those early adopters. Maybe there's something that we forgot along the way because we weren't aware of either the numbers or the processes from that information.
That's
great.
exciting. You're funding that.
Yes.
Well, that informatics is the hot spot right now. So we do have a lot of interested researchers, coming into that area using the Trinetics, using the Cosmos to start their research, and a lot of students showing interest in that. So we're excited for that.
I would say next for me, I'm learning a lot. And I think one of the things as I am going through this process of medical device implementation, it makes me think about de-implementation. So even as I've gone through this space and I'm like, hey, I can put this at the bedside, right? And this is something that can be done. How do we kind of meet the healthcare environments where they are to make sure that people are still getting good care, but it's not necessarily dependent upon, let's say, a facility needing to purchase something. The other thing is, as I mentioned, just with this space of thinking about infection prevention, self-management amongst patients. I started with older adults, and it's like now it's grown beyond just a hospital. So I've looked at pathogens being on patients' hands that are inside of the hospital. We've looked at outpatient. We've looked at, individuals that are, let's say, maybe going into surgery. So I know like the ones that are admitted, I know the ones that are outpatient, I know the ones that are coming in, I know that they have pathogens on their hand, which are deadly germs that can lead to infections. So now it comes down to the home environment and what in the home environment can be potentially influencing those pathogens that can translate into infections. So my area of interest that I am now getting into and have been maybe for the last 3 years has been specifically around hygiene poverty and just the inability for people to be able to afford environmental as well as personal hygiene items, and how is that influencing health outcomes, particularly as it relates to heightened or increased risk for infections.
Yeah. This is a little maybe off script, but I'm curious because of the influencers that maybe you had talked about previously. And there's a lot of misinformation online as well. People who are self-prescribed doctors on the internet, or, the doctors who do put themselves on Doc Talk to, give the tips and tricks. How does that maybe negatively impact what you are both trying to achieve?
May I add first?
Go for it.
So one of the things about electronic health record data is we only have data on patients who show up and the care they receive. So one of my interests is in depression, and some patients receive depression treatment within our health system. Some patients receive it at other health systems or outside providers. Some patients receive it online. And I have to be acutely aware of the percent of patients I expect to receive it in the health system, and then like missing not at random, that who is missing and why. And to go to your point about hand hygiene at home and increased risk, some patients might be at more increased risk based on other outside factors besides them. And how you think about those like influencers that could be receiving care online, it could be living in a particular area, it could be having something else that it makes it more or less important, though hand hygiene is probably always important.
Absolutely.
Well, I could also see somebody saying, well, I saw it on the internet. You hear that phrase so much. Well, I saw it online, or I didn't have the money, so I saw this fast track or this shortcut to do it myself. And so have you, maybe experienced that yourself?
Somebody could live in deplorable conditions and may not have resources to, let's say, cleaning supplies, like in their environment. There's basic things that can still help them to be able to clean that, unfortunately, sometimes a standard way of doing things is the more expensive way of doing it, opposed to being able to provide something that's maybe an economical option that's going to decrease their risk still. So it may not get rid of it completely, but it's still an option that's going to put them in a safer condition than what they would have prior been in. I'm always going to say, so one of my mentors, Dr. May Weichel, said, publish or perish. And also, as I mentioned before, just continuing to do the work. I will tell you, as you can imagine, even with everything going on with healthcare, COVID, you often get the naysayers, the misinformation, the disinformation. That information is going to come. But I remind people, I'm doing the work. I'm there. I have firsthand knowledge. I'm sharing the data in a way in which the communities can be able to understand. That's the best, honestly, that we can do, to be able to, let's say, counteract that. Is to just continue to be ourselves and continue to do the work. Because there is going to be that. I will be honest. I have it within my own family. I'm a nurse, okay? And I'll make recommendations of when somebody should go get preventative care. I'll tell somebody like, hey, you probably should go get that looked at. And guess what? They don't listen. Love them, but they don't listen. And even too, like you could, I'm sure do the same thing. And so,
oh, I do to my parents.
Exactly. And they say that they become our kids, right? Like as they get older. And so I do believe that. And you, again, are the trusted voice. You're in healthcare. And so to say that, like we experience it all in our day-to-day lives, that it prepares us for the rest of the world who may not be ready, but you can just reach somebody one message at a time. Being responsible in regards to what it is that you're sharing, making sure that you're a part of the solution and not necessarily a part of the problem, just because there is going to be the overwhelming noise. And you are going to have people, that are pseudo doctors because they have access to ChatGPT and all of these other things that just pretty much kind of like tell them like, oh no, this is what it said I need to do. I need to jimmy rig this. I need to fix this, need this away. So we just know that it's going to be out there. But as providers, as scientists, as nurses, as researchers, when we're looking at data, just doing anything, we just have to make sure, am I being a good steward of this? Am I making sure that I'm providing the most accurate information? And am I being honest of when I don't know what I don't know? And as long as we're in that space of knowing that science is about discovery, it is about asking those questions instead of having the answers, then I think we'll be fine. I think we will outride the wave of misinformation and disinformation.
Great. I couldn't have said it more perfectly than that. And Liz, is there anything that you would like to say to maybe future researchers about what's to come? I think Shanina said it perfectly. It's kind of stay true to yourself, believe in what you believe and really stick to that path. What else could we impart? What wisdoms do we have?
I get the joy of working with medical students oftentimes or meeting with people. I think talking to multiple mentors, understanding their pathway, to what extent their pathway works for you, to understand what their methodology works for you. There's always benefits and pitfalls to every methodology. So understanding what you're picking and why, who you're learning from, what their biases are, because I have my biases, right? Like we all have them. And being able to say like, this is what I want to do, and building that path forward and understanding the path is not linear. You are going to You're gonna meet roadblocks. You're gonna get rejected. The R34 I just told you about, I will say, was probably rejected 4 times locally before I got it funded by NIH. And normally you would say if it's not funded locally, why go to NIH? But like believing in yourself, believing in the idea, and then also saying like, hey, this isn't working for people. Why? What am I missing in my narrow perspective that I need to add so that somebody else can see what I'm trying to say? So that's
And it sounds like some self-reflection there.
Well, thank you both so much for an engaging conversation today. I really enjoyed this, and I would love to stick around for another hour asking more questions. But unfortunately, we are out of time today. For our listeners, we would love for you to get engaged with the CTSC if you're interested in funding, course support, training methods, emerging technologies. Visit us online on our website. Of course, subscribe to our podcast and share with your colleagues who are exploring new research tools and looking to explore new connections. And actually, we do have a fun announcement that our K just got funded again. So we are excited to maybe have new future K scholars coming onto our podcast in the future. So thank you both so much, and we look forward to seeing what's next.
Yes. And the KLTM program's awesome.
Yes, it is. I have to give absolutely high recommendations.
Wonderful.
Yeah,
Thank you both.
Thank you.